Hello, doctors. Um, good day, good day. I know some people were saying, let's go. Please, can you let me know whether or not you can see me and can you hear me? I want to know, please. I really want to know because I think I'm having issues with my camera. Please, can you see me? One, and can you hear me? Two, I want to know, please, can you see me and can you hear me? And if yes, are we good to go? Please, here I am. Here I am. Can you see me? And can you hear me? I'm having issues with my camera today. Okay, you can hear me. Can you see me? Those are two different things. You can hear and you can see. Please don't just tell me yes. I want to know whether you can get both. Okay, I'm audible enough. What about, can you see me? Can you see me? Okay, so one and two. Good. Thank you very much. Thank you very much. I was struggling with my camera, so I didn't know what to do. And I didn't know how to come live if my camera is not working. So, you know what? Here we go. So, thank you very much, doctors. The numbers keep increasing. The numbers keep increasing. Please tell your friends, share it in your various WhatsApp groups, your various, study groups and everything, and let people join right away. Okay? Please. Let me see. Go. We are going right away. We are starting right away. Um, so I just didn't know because I'm not very tech savvy, so I didn't know what to do. Oh my goodness, Dr. Boni needs to learn some tech, right? I need to learn some tech. All right, so doctors, let's get going. Today's class, in fact, I'm excited about it because of two things. A lot of candidates struggle with this, and I'm praying and hoping that by the time the class is done, you can say, Dr. Bruni, for this particular problem, I'm done with it. Okay? So please make sure that you are watching us on YouTube as well. Go to our YouTube, click on our like and subscribe button, and then just share it as well, even from YouTube to your friends. Because if we can help grow this channel, then we can get as many doctors to see this as well. So I'm going to jump right into it because we've taken a lot of time. Please get your friends to join, okay? Now, we are dealing with this very important objective, polyuria and polydipsia. And I want to find out from the comment section, please, how many of you struggle with the concept of polyuria, polydipsia, diabetes insipidus, nephrogenic diabetes, diabetes central, diabetes insipidus, um, um, especially those two things? How many people struggle with it? I just want to know, because I think that before I prepared for this, I did a little survey, and a lot of people were saying that, look, um, a lot of people were saying that they are struggling with the issue, so they want us to deal with it. Okay, so please let me know, is it a bother? Because today we're going to dive really deep into it. We're going to dive really deep into it. Okay, all right, so let's jump in. So when it comes to approach to polyuria and polydipsia, this is what the medical council says. It says that although polyuria and polydipsia is not common, remember that all throughout the objectives we are learning, what is one word we see? What is one word we see? What is one word we see? I want to know. What is one word that we see a lot of the time? Please, a lot of the time. What is that one word? Which helps us to know that this is a very important topic for the MCQE1. I want to know, what is that one word? What is that one word? Because I'm reading this rationale, and then you are going to understand why the medical council wants you to know. Beautiful. So Dr. Sabine just said, common things, common things, common things. So you realize that, look at the way they started the whole preamble. Look at the way they started it. They said that although it is not common, okay, so why should we learn it? Polyuria and or polydipsia may be the presenting symptoms of a potentially serious underlying condition. So they agree that, look, this topic we are about to learn may not be very common like the other things we've done, chest pain, abdominal pain, and all those things, right? But the reason why you need to know it for the MCQ1 exam is because it can be the presenting symptom of a potentially serious underlying condition. And remember the essence of MCQE1. The essence of MCQE1 is whether you are Dr. Sabine, Dr. Robert, Dr. Isaac Tool, anyone, you should be able to keep patients alive. That is the first thing, right? So although it is not a common thing, polyuria and polydipsia may be presenting symptoms of a potentially serious underlying condition, and it may be confused with urinary frequency, which is a common complaint. So polyuria and polydipsia is not common, but you need to learn it for the MCQE1. Why? Because it can be the presentation for a serious medical condition. Now, a lot of doctors confuse that with urinary frequency, which is a common issue. Okay. Now, what are the causal conditions? Number one, water diuresis, which is like, patients who take in excessive amounts of water. So you see my big jug, this is my water bottle that I take to work, right? Excessive amounts of water. And excessive loss can be from diabetes insipidus, okay? And it can also be from osmotic diuresis, where, the patient has a buildup of sugar in the body, like diabetes mellitus. When patients also have a buildup of urea, that is chronic renal disease. And when patients have a buildup of salt, that is organic anions, okay? So you have to understand that it is not common, but why do we need to master it for the MCQE1? Because if you don't master it and someone presents and you say, oh, this is just urinary frequency, that can be a life or death decision you are making for somebody. Okay. Now, what are the key objectives? Given a patient who presents with polyuria and or polydipsia, the candidate, or let me say the doctor, will diagnose the cause, the severity, and the complications, and will initiate an appropriate management plan. Right? Will initiate an appropriate management plan. Now, given a patient with polyuria and or polydipsia, the candidate will list and interpret critical clinical findings, including how to diagnose polyuria and polydipsia, the causal factors, the severity, and differentiating urinary frequency from polyuria. That's number one. Number two, inquire about any personal or family history of diabetes. Number three, identify neurologic features that may suggest intracranial pathology as a cause of central diabetes insipidus. So doctors, today, by the time we are done, diabetes insipidus will be put to bed. Okay, now list and interpret critical investigations, including tests which distinguish between water and osmotic diuresis, screening for diabetes, use of avoiding diarrhea when appropriate, okay, and construct an effective initial management plan, including management of the underlying cause, determination as to whether the patient requires specialized care. So these are the enabling objectives you need to master for the exam. Now, before we get into the class, I want to draw attention to one thing or two things. Doctors, please click on the like and the subscribe button on YouTube. Do that. We have just 1,700 subscribers. Help us to grow it, okay? Please help us to grow it in real time. Help us to grow it. We have more than 100 people on the class right now. Kindly, help us to grow this thing right away. And then I want to remind you. I want to really remind you of this very important. I'm just checking. We have how many people do we have as our subscribers today on YouTube? I'm just checking that and I'll let you know. Okay. We just have about 1,796. So please move us to 1,900. Please move us to 1,900 today. Okay. Good. So now, before we even move on, I want you to understand what we are doing in MedCognito because of the intensity of the exam going forward. We've introduced the concept of med drills, and we're going to do 2 med drills in February. Every month, we choose what area candidates see as a weakness, and we do med drills in. Last month, we did med drills in ethics. This month, the candidates said they want us to do med drills in psychiatry. So this month, I'm going to spend 2 days with them, okay, on February 10th and February 18th to go through med drills. You decide on what you want us to review, especially if it's a weakness, and we go through it. Now, it is open for everybody, whether you are a MedCognito candidate or you're not a MedCognito candidate, right? And after the class, candidates are very happy with what they are getting. because we want to make sure that we've sharpened you for the exam. So February 10th, please mark your calendar, and February 18th, because some people are taking a Nakoski class as well. So we have brought in an initial date, but they said that Dr. Bruni, it conflicts. And so we moved it to February 10th and February 18th. Come and get drilled, bombarded and thoroughly prepared for the psychiatry class. And you can use this link to register. If you're in MedCognito, it is free. It is free for you. But if you're not in MedCognito, you just pay a token and you join the class, okay? So just mark your calendar. Even if you join for 1 month, for MedCognito for 1 month, you get access to everything we have, and you also get access to this med drill as well. So let's get into today's class. Reviewing questions about introduction to polyuria and polydipsia. This is the first question. You have a 47-year-old man who presents to the emergency department with complaints of excessive thirst and frequent urination that have progressively worsened over the past few weeks. And I'm going to really take my time with these questions and this topic today, okay? His history is significant for a recent transsphenoidal resection of a pituitary macroadenoma. He denies any recent illness, fever, or urinary tract symptoms. And physical examination reveals dry mucous membranes and mild tachycardia. His serum sodium is 149. So it looks like his serum sodium is just a little high. His plasma osmolality is 310. So just a little high and just a little above normal. And his urine osmolality, in other words, his urine concentration is 150. So that is really, really low. Which of the following is the most likely diagnosis? Doctors, this is a topic a lot of candidates struggle with. Please don't hesitate to invite your friends. Invite your friends to join us so that they can also get the best out of this, okay? Please, I really, really want the IMG community to be able to master this particular topic because people struggle with it. So number one, what's the most likely diagnosis? A, primary polydipsia. B, central diabetes insipidus. C, nephrogenic diabetes insipidus. D, syndrome of inappropriate ADH secretion. And E, psychogenic water intoxication. I want to know what the correct answer is. Is it A? Is it B? Is it C? Is it D? Or is it E? Primary polydipsia, central diabetes insipidus, nephrogenic diabetes insipidus, syndrome of inappropriate ADH secretion, and psychogenic water intoxication. Please, what is the answer? I see that Dr. Robert is going for D, while, I think Dr. Maria rather went for D. Dr. Robert went for B, B. Dr. Glory went for B as well. Looks like many people went for B, stating it is rather central diabetes insipidus. What is the correct answer? What's the rationale? The correct answer is B. Correct answer is B. Central diabetes insipidus. So this patient has polyuria. Let's look at the rationale very well, okay? And I'm going to, after that, take my time and we're going to break it down. This patient has polyuria, polydipsia, and hypernatremia, increased sodium in the blood after a pituitary surgery. So that is something I want you to really put in your mind. In the board exam, in a patient who has increased tests, drinking a lot of water, in a patient who is peeing a lot, and then you check the sodium level in the blood, and the sodium is high. Because you were expecting that since the patient is drinking a lot of water, the sodium level may be low, right? Start thinking about central diabetes insipidus. Please, doctors, start thinking about central diabetes insipidus. Now, central diabetes insipidus is, why should I think about that? Because it is caused by impaired release of arginine vasopressin, or ADH. That's what we call antidiuretic hormone, okay? Now, you realize that in this class, I'll be using the word arginine vasopressin very well. Not vasopressin, it's vasopressin, okay? Due to the damage to the hypothalamic osmoreceptors and supraoptic and paraventricular nuclei or supra-ophthalmopterous tract, right? And the hallmark is hypernatremia with low serum osmolality and high plasma osmolality. So if you want to understand, like first things first, central diabetes insipidus, what is happening there? The patient is drinking a lot of water. The patient is peeing a lot of water out. And the patient has high sodium levels in the blood. All right. And usually look out for that patient who recently had a head injury, who had like surgery around the head. Look for that particular patient in your board exam, right? Whether you're taking the USMLE, the AMC, the MCCQE1, the PLAB, these are the things you want to look out for. Now, why is primary polydipsia wrong? Usually, so this is something I would have written down if I'm taking notes. Please write this down. In primary polydipsia, unlike central diabetes insipidus, the patient will present with low sodium in the blood. Please write that down. So in primary polydipsia, both and central diabetes insipidus, both patients drink a lot of water. But in primary polydipsia, sodium levels are low in the blood. In diabetes insipidus central, sodium levels are elevated. So please write that down. Please write that down before we move on. Primary polydipsia, drinks a lot of water. Central diabetes insipidus, drinks a lot of water. Primary polydipsia, sodium level is low. Central diabetes insipidus, sodium level is high. Doctors, please, does that make sense? Can I move on? I want to take time so that we can break it down. Now, Dr. Ebironke says something here. Diabetes insipidus, the patient is dry inside and then wet. She's saying something there, but I will come to that equation, okay? Then let's go to nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus, so that is even telling you that, look, when you're learning diabetes insipidus, you should remember that there are two main different types, central and nephrogenic. Nephrogenic diabetes insipidus, the patient will have normal arginine vasopressin or normal antidiuretic hormone, but then they have inability to concentrate urine. So what's the key difference between primary polydipsia and central diabetes insipidus? Even though both of them drink a lot of water, primary polydipsia has low sodium in the blood. Central diabetes insipidus has high sodium in the blood. When I go to central diabetes insipidus and nephrogenic diabetes insipidus, central diabetes insipidus has low antidiuretic hormone or arginine vasopressin, low. But then in nephrogenic diabetes insipidus, arginine vasopressin or antidiuretic hormone is normal or high. Doctors, please write this down. I plead with you, because we are not running anywhere. We are staying here till we get these concepts right. D, why is syndrome of inappropriate ADA secretion wrong? Usually, syndrome of inappropriate ADA secretion, if you take sodium and you take the urine concentration, you realize that the sodium level in the blood is low, but the urine concentration is high. That's syndrome of inappropriate ADA secretion. But when it comes to central diabetes insipidus, you realize that sodium levels in the blood is high and urine concentration is low. So it looks like syndrome of inappropriate ADA secretion is the opposite of central diabetes insipidus. Okay? And then if we go to psychogenic water intoxication, that causes hyponatremia. That is low sodium in the blood, not hypernatremia. Doctors, before I move on, this slide alone, please, does it make sense? If it doesn't make sense, tell me. I will go through everything again, point by point by point by point. I'm not moving away until you give me the go-ahead to do so. I'm not moving away until you give me the go-ahead to do so. Today, I want us to take our time to break these concepts down so that you can go into your board exam, the MCCQE1, with a lot of confidence. Tell me, can I move on or no? Even if one person says they don't understand, I'm going to take my time and review it. Okay. Dr. Khadija says I should go through it again. Dr. Khadija, what we are, so this is her request. I will take my time. So there are a lot of concepts in this particular one slide. There are a lot of concepts in this particular one slide. Number one is central diabetes insipidus. Number two is nephrogenic diabetes insipidus. Number three is primary polydipsia. Number four is syndrome of inappropriate ADH secretion. After that, we're going to do some calculations. I'm going to give you some equations so that I will know whether you got it right or wrong. In fact, those equations come just after this. Okay. In your board exam, please write this down. If you see a patient who recently had surgery to the brain, or to the head, somewhere on the head, and that patient presents with increased thirst, drinking a lot of water, peeing a lot, urinating a lot, and the sodium in the blood is elevated, think about central diabetes insipidus. Please, is that point clear? If that point is clear, tell me. Central diabetes insipidus, look for a patient who recently had surgery or trauma to the head, presenting with polyuria, polydipsia, and elevated sodium in the blood. Please, can I move on? I want to make sure. All right, so that's number one. Central diabetes insipidus, nailed. Right? Now, with central diabetes insipidus as well, the sodium, the urine concentration is very low. So let me say it again. Patient with recent head injury or head surgery, patient who is urinating a lot, patient who is drinking a lot of water, sodium levels are high in the blood, and the urine is very, very, very light in concentration. Central diabetes insipidus. Please, are we good there? Are we good? Okay. Number two, primary, in fact, let me move to nephrogenic diabetes insipidus. Another feature of central diabetes insipidus I want you to remember is AVP, or antidiuretic hormone, is low. Okay, so low antidiuretic hormone, polydipsia, polyuria, low serum urine osmolality, but sodium high. Think about central diabetes insipidus. Now let's go to nephrogenic diabetes insipidus. So what I mean by urine concentration is low is I mean osmolality. The urine osmolality is low. Okay, urine osmolality is low. Urine osmolality is low in central diabetes insipidus. Nephrogenic diabetes insipidus, let's go through the same thing. The AVP, arginine vasopressin, is normal, but then you realize that the urine osmolality is also low. So it presents similarly as central diabetes insipidus, but the main thing here is that the AVP, or the antidiuretic hormone, is normal or high. That's central diabetes insipidus. That's nephrogenic diabetes insipidus for you. Okay, doctors, please, can I move on from there as well? I want to know. I don't want to rush this class at all. We are taking our time. We are breaking down the concepts until we understand. Can I move on from nephrogenic diabetes insipidus? Nephrogenic diabetes insipidus. Can I move on? Can I move on from nephrogenic diabetes insipidus? Okay. Now, another thing, primary polydipsia. Primary polydipsia. Patient will present with low sodium levels in the blood. Meanwhile, central diabetes insipidus and nephrogenic diabetes insipidus, sodium level was high in the blood. But primary polydipsia, sodium levels are low. Why? Because the patient is just drinking a lot of water. There's no problem with, like, the patient does not have diabetes insipidus. And then syndrome of inappropriate ADH secretion. In that situation, sodium levels in the blood are low, but the urine concentration, the urine osmolality is high. Hello, doctors. Syndrome of inappropriate ADH secretion. Let me say it again. Sodium levels in the blood are low, and the urine concentration or the urine osmolality is high. Doctors, please, does that also make sense? I'm just giving you the broad strokes. This is just the first question. We have so many questions coming up. Can I move on from syndrome of inappropriate ADH secretion as well? So in your book, all you need to do is write central diabetes insipidus, nephrogenic diabetes insipidus, syndrome of inappropriate ADH secretion, primary polydipsia, and then write sodium, antidiuretic hormone or adrenaline vasopressin, urine osmolality, and then you put arrows. This is up, this is low, this is up, this is low. All right. And then psychogenic water intoxication, it's similar to primary polydipsia. Okay. Now, people are confused about AVP and then diabetes insipidus. Adrenaline vasopressin deficiency is the same as what we call antidiuretic hormone deficiency. Okay, adrenaline vasopressin deficiency is the same as antidiuretic hormone deficiency, and I'm using this because this is the new nomenclature. Now they don't call it diabetes insipidus anymore. If you go to the recent literature, if you check up to date and the rest, they rather call it adrenaline vasopressin deficiency. So that's why I use that. Okay. All right. So doctors, let's try some equations like what we do. Number one, you have a patient. The patient has polyuria with polydipsia with hypernatremia, and then when you check the urine osmolality is low, but the plasma osmolality is high. What's your diagnosis? We've gone through this in the first slide, but I wanted to put it in equation forms so that we'll see if you got it. You have a patient, polyuria, polydipsia, urine, blood sodium levels are high, but then the urine osmolality is low. What's your diagnosis? I'm going to wait for as many people as possible to write their answers. Doctors, while you are doing that, please don't forget to subscribe to our YouTube channel, please. Okay, so we can grow it with you. We want to hit 2,000 subscribers by the end of this class. Okay. All right. So it looks like everyone is going for diabetes insipidus, central diabetes insipidus. So that is the correct answer, because I want to bring these things out so that we can get it right. Okay. Next equation. The patient is drinking excessive water, and it is leading to decreased sodium, decreased plasma osmolality, decreased urine osmolality. You have a patient drinking excessive water, leading to decreased serum sodium, decreased plasma osmolality, decreased urine osmolality. Help me with this equation. What is your answer? I like these equations because then they help us to really get the concepts right. Excessive water intake leading to decreased serum sodium, leading to plus decreased osmolality with decreased osmolality, decreased plasma osmolality and decreased urine osmolality. What's your answer? So a lot of people are going with primary polydipsia. Beautiful. So this is primary polydipsia. Doctors, please, I hope I'm not running too fast. Please, I want to know. I want to take my time. I hope I'm not running too fast today. Please, please, please. Am I running too fast? I want to know from the comments. Am I running too fast? Am I running too fast, please? Okay, let's move on to the next equation. This patient has normal or elevated arginine vasopressin levels or antidiuretic hormone levels. You gave antidiuretic hormone or arginine vasopressin, and it looks like there was decreased kidney response to AVP. Now, there is increased water loss, increased plasma osmolality, and still the urine osmolality is low. What is your answer? What is your answer? I really like the, how our French speakers are really commenting. So, what is your answer? Normal or increased AVP, decreased renal response to AVP, leading to increased free water loss, leading to increased osmolality and decreased osmolality. Increased plasma osmolality and decreased urine osmolality. What's the correct answer? Good. This is nephrogenic diabetes insipidus. Doctors, please, is it becoming easier? Now, I want to find out, please. I don't want to rush anybody. Is it becoming easier? Remember, we've not gotten into the lecture yet. This is just the first question, and we are breaking it down with equations. Is it becoming easier? Please. We have more than 100 people on this stream. Is it becoming easier? Please. Is it becoming easier and simple? Please. I want to know. Okay, good. Next question. You have a patient with hyponatremia. And that same patient has decreased plasma osmolality. But the urine osmolality is elevated. And it is not that the patient is hypovolemic or has fluid overload in the blood. What's your diagnosis? Frankly, I even think that after these equations, we can call it off. Hyponatremia, plasma osmolality is decreased, urine osmolality is increased, and the patient is euvolemic. What's your diagnosis? My goodness, doctors, I'm so happy because syndrome of inappropriate ADH secretion. Oh my goodness, this is wonderful to see. Please, will you ever forget central diabetes insipidus, nephrogenic diabetes insipidus, syndrome of inappropriate ADH secretion? Will you be able to forget any of these? Please, I want to know, because this is wonderful to see. This is just the first part of the class. Okay, doctors, now can I move on? I want to know, can I move on? Today we are going to beat polyuria and polydipsia to the ground. Can I move on? Can I move on? Dr. Khadija says no, I should not move on. Okay, I should move on. All right, sure. So after those equations, I bring you this question. You have a 50-year-old woman with a history of hypothalamic glioma who presents with polyuria, polydipsia, and signs of dehydration. MRI of the brain shows destruction of the supraoptic and paraventricular nuclei. Which of the following would be the best initial treatment? A, free water restriction. B, hydrochlorothiazide. C, desmopressin. D, democlocycline. E, hypertonic saline. What's the correct answer? Is it A? Is it B? Is it C? Or is it D? I think somebody just asked the question. Dr. Boni, what happens to ADH in primary polydipsia? In primary polydipsia, ADH remains the same. To remain normal. Okay, to remain normal. Okay. Now let's go to the answers for this question. So you have a 50-year-old woman who presents with hypothalamic glioma, polyuria, polydipsia, signs of dehydration. MRI of the brain shows distraction of the supraoptic and paraventricular nuclei. Which of the following would be the best initial treatment? And the correct answer is desmopressin. So this patient has ABP deficiency due to the hypothalamic damage from that surgery, and therefore the patient develops central diabetes insipidus, right? Now, desmopressin is a synthetic arginine vasopressin or antidiuretic analog, and therefore that is the treatment of choice. If you do water restriction, what you're going to do is that, remember that in diabetes insipidus, central diabetes insipidus, they already have elevated sodium in the blood, and if you're going to prevent them from drinking water, you are going to make their elevated sodium worse. So if you restrict sodium water in a patient who has central diabetes insipidus, trouble, right? You are causing big trouble for that patient, because you are giving that patient, you are making it difficult for that patient. Okay, what about hydrochlorothiazide? We'll come there. But remember that hydrochlorothiazide is used for the management of nephrogenic diabetes insipidus, not central diabetes insipidus. So if I were you, I'll write this down. Water restriction is dangerous. So those times you used to do CDM exam, right? Last year, if you had this as a CDM case in a mock exam and you chose water restriction, it would have been every other thing you'd have chosen would have been 0, because that's a dangerous answer, right? But we are no longer doing CDM, so that's great. Hydrochlorothiazide is used for the management of nephrogenic diabetes insipidus, not central diabetes insipidus. And democycline or demiclocycline is used for the management of syndrome of inappropriate ADH secretion, not central diabetes insipidus. And hypertonic saline is used in severe symptomatic hypernatremia, not the first line. Okay, so now let's go to the next one. You have a 45-year-old male who is diagnosed with central diabetes insipidus following resection of a craniopharyngioma. After starting desmopressin, so look at this, the person developed diabetes insipidus, and we've learned that with central diabetes insipidus we give desmopressin, right? So this person, the question is that after you started desmopressin, this patient develops confusion and lethargy, and then you repeat his blood work and it shows that his serum sodium is 125 milliequivalents per liter. So that is low. His plasma osmolality is 260. Which of the following is the most likely cause of his new symptoms? A, overcorrection of the hypernatremia. B, cerebral salt wasting. C, adrenal insufficiency. D, lithium toxicity. And E, hyperosmolar hyperglycemia. What's the correct answer? And this question is basically testing you on the complications of desmopressin use. Complications of desmopressin use. So if you know the complications of desmopressin use, you'll be able to answer this question, right? 45-year-old male diagnosed with central diabetes insipidus following resection of a craniopharyngioma. After starting desmopressin, he develops confusion and lethargy. Repeat blood work shows low sodium. Plasma osmolality is 206. What's the correct answer? The correct answer is A. It is because the hypernatremia was overcorrected, right? So desmopressin, now this is another learning point, so please write this down in your book. Please write it down. Desmopressin use in central diabetes insipidus can cause hyponatremia. Remember that in diabetes insipidus, the patient has hypernatremia. Now, when you give the desmopressin, it can swing the patient from hypernatremia to hyponatremia, especially if fluid intake is excessive. And when you overcorrect central diabetes insipidus with desmopressin, that can lead to cerebral edema and neurologic symptoms. That is why the patient started presenting with confusion. Doctors, please, are we all on the same page? Are we all on the same page? I want to make sure that we go step by step by step by step by step. We're going step by step by step by step, please. Okay? Why is cerebral salt wasting wrong? Cerebral salt wasting causes hypovolemia with high urine sodium. And that is not what we see here. What about adrenal insufficiency? Adrenal insufficiency causes hyponatremia with hyperkalemia. That's not what we see here. Lithium toxicity can lead to nephrogenic diabetes insipidus. So doctors, remember, while brain surgeries lead to central diabetes insipidus, lithium toxicity leads to nephrogenic diabetes insipidus. So in these few slides, we've learned a lot, okay? And what about hyposmolar hyperglycemia? Hyposmolar hyperglycemia causes hypernatremia, not hyponatremia. So doctors, please, let me say it again. Today, you need to write so much in your notebooks. Overcorrection of hypernatremia with desmopressin can lead to hyponatremia, which can lead to neurologic symptoms and cerebral edema. Okay? Adrenal insufficiency can cause hyponatremia with hyperkalemia. Lithium toxicity, never get confused about that. Lithium toxicity can cause nephrogenic diabetes insipidus, not central diabetes insipidus. And hyposmolar hyperglycemia causes hypernatremia, not hyponatremia. Let's move on to the next question. Or let's move on to the next thing. So doctors, now that we've finished all those questions, we are now going to just start with the introduction. Introduction. We've already done almost 15 minutes of class. We are now coming to start introduction to diabetes insipidus. Please, are we all tracking together? Are we all tracking together? If yes, type yes, yes, yes. Let me know. Are we all tracking together? I want to know. Are we all tracking together? Please, doctors, are we all tracking together? I want to know. I really, 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 really want to know. Okay. Okay, good. So, before we get to the introduction, just want to know, why are we doing this? We are doing this for the IMG community because we want to bring ourselves at par and make sure that we get in very deep. So far as matching for residency and matching for practice ready assessment is concerned. Remember that this wasn't last week, even for TDM, that is therapeutic decision making. Now they've changed the rules, right? So initially TDM was 40 questions, and each question has about 3 sub questions, and so in total you're doing about 100 questions, and it was filling. Now come January 2026, for those who are planning on doing practice ready assessment, TDM is going to have MCQs as well. So that means that now you can't read on the surface for TDM. You've got to go deep. Okay. Now, one candidate after the last webinar said, boy, oh boy, words fail me. By the way, you demystified scabies. I was multitasking with questions from HQ Bank and UWorld on scabies while the class was ongoing. Now I could answer the questions on scabies confidently. Hey, Dr. Bruni, you nailed it like a bulldozer. You made me love dermatology. I'm so speechless. How do you do it? That's the same way I want you to appreciate diabetes insipidus today. Okay? And I want you to understand that you can have everything we do in MedCognito for just $2,199 for 6 months, or $450 a month for 1 month access, or you can use a payment plan. If you're interested after the class, you can reach out and we can walk through it. Okay. So we have various packages, the 6 months and then a 1 month package. So now let's go back to the introduction. Diabetes insipidus is an old name. If you check your up-to-date right now, you realize that diabetes insipidus is no longer, they don't use it. They usually talk about arginine vasopressin deficiency. Okay, so that's why I started with that, arginine vasopressin deficiency. And that's the same name for arginine vasopressin deficiency, is the same name for antidiuretic hormone deficiency. Okay, now arginine vasopressin deficiency results in the patient urinating a lot, polyuria, that's excessive urination. And this is because there's impaired water retention. So remember the name, antidiuretic hormone. Now, diuresis means the patient is urinating a lot. Antidiuresis means that hormone was supposed to prevent the patient from urinating a lot. Now, if you have a deficiency of that hormone, which was to prevent you from urinating a lot, guess what? You will urinate a lot, right? So, less antidiuretic hormone means you are going to urinate a lot. That is very simple. And remember that another name for antidiuretic hormone is arginine vasopressin. Please, I want to make sure that we don't confuse anybody. What is diuresis? Diuresis means you're going to urinate a lot, right? So if there's a hormone in the patient's body, which is called antidiuretic hormone, that means that hormone prevents the patient from urinating a lot. Now, if you have a patient who lacks or who has a deficiency in antidiuretic hormone, that means that that patient is going to urinate a lot. That is all that diabetes insipidus is about. Now, why is it that when patients have brain surgery or some form of intracranial surgery, they can develop diabetes insipidus? Because an antidiuretic hormone is made or released from different parts of the brain. Okay, so like the hypothalamus, like the supraoptic and the paraventricular nuclei, like the supraoptical hypophyseal tract, like the posterior pituitary gland, and they release AVP into the bloodstream. So I just brought this up. You don't need to really learn this for MCCQE1, right? But remember that if there's a damage to any of these parts in the brain, that can lead to polyuria. That's why I put it here, that forget about all the above. It is just for academic purposes, right? Not needed for the boards. But I just wanted to bring it up so that you realize that if the patient is having surgery in any of these parts of the brain, there can be trouble. Okay, what causes antidiuretic hormone deficiency? Number one, tumors. So if you have a patient with craniopharyngioma, a pituitary tumor, anything in the brain, think about it. Okay. Number two, operations. So surgeries. So if anyone has any surgery near the hypothalamus or the pituitary gland, trouble. Okay. Number three, post-trauma. So if you have a patient who had head injury, that was when we started the class, I was talking about it. Head injury, brain surgery, brain ischemia, whatever. That can also lead to decreased antidiuretic hormone release, and that can lead to diabetes insipidus. Number four, inflammatory concerns and infections. So like a patient who has meningitis, tuberculosis, sarcoidosis, right? The next one, congenital issues. So Wolfram syndrome, septo-optic dysplasia. So these ones you must know, and you don't need to know it in detail, but you must know that, okay, if a patient has a brain tumor, a brain surgery, or a brain injury, right, or a brain infection, or a congenital issue affecting the brain, these can all lead to abnormal antidiuretic hormone release and therefore lead to diabetes insipidus. So if you want to remember that, remember the word topic. Tumors, operations, post-trauma, inflammatory issues, and congenital issues. The word topic. Okay, good. So now let's look at how we can link polyuria with polydipsia and population health. Okay. Someone says I should go to the previous slide. I want to check which one. Dr. Isaac, please, is that okay? Dr. Nuri, you said I should go to the previous slide. Is that okay? Okay. All right. So now let's go to polyuria, polydipsia, and population health. Why am I saying that? Because in your MCQ1 preparation, don't only learn hard facts, try to connect the facts. Okay. So I'm going to ask you a question here. A 35-year-old male with known central diabetes insipidus asks whether his condition might affect his daughter. He was diagnosed at the age of 29 after undergoing craniopharyngioma resection. He has no family history of polyuria or endocrine disorders. What was the most appropriate response to his concern? A. Your condition is likely genetic and your daughter may inherit it. B. ABPD, that is antidiuretic hormone deficiency, is predominantly an X-linked disorder, so only males in your family are at risk. C. Most cases of ABPD are acquired and not inherited, so your daughter is unlikely to be affected. D. ABPD has equal prevalence in males and females, but your daughter has a 50% chance of inheriting the condition. E. Your daughter should undergo genetic testing because all cases of ABPD have an underlying genetic mutation. For the doctors who are asking about the previous slide, I think you are in MedCognito class. What I'll do is after the class, just send me a WhatsApp message. I will take a screenshot and send it to you. I don't really know exactly what you are talking about, but let's go on. After the class, I will take a screenshot and then send it to you, please. Okay. So what's the correct answer? Because now we are trying to link diabetes insipidus with population health. Okay, you're trying to link diabetes insipidus with population health. And I can see a lot of people going for C. The correct answer is C. Why? Most cases of diabetes insipidus are acquired and not inherited. So your daughter is unlikely to be affected. Okay, so that's one thing. That's one thing you need to know. Now, ABPDs, when I use the word ABPD, that is the central diabetes insipidus. And when I use the word AVPR, I'm talking about nephrogenic diabetes insipidus. So let me go back. ABPD is acquired in 95% of cases. We learned about it already. Trauma, tumors, central infections, right? AVPR, that is nephrogenic diabetes insipidus, is often X-linked. So when it comes to nephrogenic diabetes insipidus, you are thinking about an X-linked issue. But central diabetes insipidus is 95% of the cases are acquired. Okay. Genetic AVPD, because remember AVPD, we are talking about central diabetes insipidus, is rare. So testing in all cases is unnecessary. And when it comes to central diabetes insipidus, males and females are equally affected. But inheritance is not common. So please remember this. Let's take it again. AVPD, which is central diabetes insipidus, most of the time is acquired. Nephrogenic diabetes insipidus is X-linked. Okay, two things. When it comes to genetic inheritance of ABPD, it's just about 5% and below. So we don't test like the family members if somebody develops it. And when it comes to ABPD, males and females are equally affected. Doctors, please, is this okay? Can I move on? So remember, there's a difference between AVPD and AVPR. AVPR is nephrogenic diabetes insipidus. AVPD is central diabetes insipidus. That's all I'm saying. Can I move on, please? Can I move on? Can I move on? Okay. Next question. A newborn male is diagnosed with polyuria and hypernatremia. His urine osmolality remains low despite desmopressin administration. Doctors, before we move on, if you have a patient who has decreased urine osmolality, and hypernatremia, and you give desmopressin, and desmopressin is not working, what, before you even answer the question, before you answer this MCQ here, what diagnosis are you thinking about? Urine osmolality is low, patient has hypernatremia, and the patient is urinating a lot. What diagnosis are you thinking about? You give desmopressin, and desmopressin seems not working. Beautiful, Dr. Irene, beautiful. So Dr. Irene says it is nephrogenic, right? Nephrogenic diabetes insipidus. Remember, central diabetes insipidus will respond to desmopressin. Nephrogenic diabetes insipidus does not respond to desmopressin. So his mother has no history of diabetes insipidus. And genetic testing reveals a mutation on the AVPR2 gene was the most likely diagnosis. A, autosomal dominant AVPD. B, autosomal recessive AVPD. C, X-linked AVPR. D, mitochondrial inheritance of central diabetes insipidus. And E, acquired AVPD. Beautiful. Everybody is going for C. And that's the correct answer. Remember that we said that diabetes insipidus, majority of them is inherited. Nephrogenic diabetes insipidus, majority of them is inherited. Central diabetes insipidus, majority of them is acquired. And you'll be learning something very interesting. So the correct answer is C. X-linked AVPR, which was formerly called nephrogenic diabetes insipidus, is the most common inherited form of diabetes insipidus, and it predominantly occurs in males. I need you to remember that. Diabetes insipidus, nephrogenic type, usually commonly occurs in males. Please write it down. Doctors, please, are we breaking down the concepts? Please, I want to know, are the concepts being broken down today? I want to know, are we breaking down the concepts, please? Are we breaking them down? Are we breaking them down? Are we breaking down the concepts? Please. Nephrogenic diabetes insipidus is the most common inherited form of diabetes insipidus. Number one. Number two, it mostly occurs in males. And number three, it is X-linked. It is X-linked. Okay, AVPR2 gene mutation on the X chromosome leads to renal resistance of AVP. That is why when you give the desmopressin, it does not work. Okay. All right. So let's go into a deep dive onto it. So memory aid. AVPD is rare but acquired. That is central diabetes insipidus. So when you see here AVPD, D, think about central. AVPR, think about nephrogenic. Okay, most cases of AVPD are acquired, not genetic, and the prevalence is in 1 in 25,000 people. Genetic causes of central diabetes insipidus is less than 5%. And when it comes to central diabetes insipidus, the gender distribution is equal in both males and females. And you contrast this with AVPR. AVPR, that is nephrogenic diabetes insipidus, mostly is inherited, more common in males, and it is X-linked. Hello, doctors. Hello. We're breaking down the concepts. Next slide. So again, AVPD, I'm trying to drum it into your head. AVPD, that is central diabetes insipidus, is equal in terms of distribution in males and females. Remember, it is acquired. AVPR, which is nephrogenic diabetes insipidus, is mostly in males. Remember, it is X-linked. So tonight, when you are sleeping and somebody wakes you up, what did Dr. Bruni teach? You should be able to tell the person. Okay. So in AVPD, that is central diabetes insipidus, the brain stops making or releasing antidiuretic hormone. And because of that, the kidneys can't concentrate urine. And because of that, there's large production of urine. And because of that, there's excessive thirst, polydipsia. Therefore, I need to drink more water. Memory aid. AVPD means ADH is down. And therefore, the aquaporins disappear. And therefore, the patient's urine is dilute. Hello, doctors. Can I move on? Can I move on? I'm just re-emphasizing points we've made. Can I move on, please? Can I move on? Can I move on? Can I move on, doctors, please? Can I move on? All right. AVPD can either be acquired or congenital. We've talked about that. The acquired one is more than 95%. The genetic one is less than 5%. Okay. So remember, AVPD, central diabetes insipidus, is almost always acquired. Almost always acquired. 95% and more. Almost always acquired. Right? So now, acquired causes of AVPD. These are the common issues. It can be trauma to the head, resection of tumors like pituitary, suprasellar tumors, craniopharyngiomas. It can be autoimmune issues like, it can even be idiopathic issues. It can be metastatic cancer from the lungs, the breast, leukemia, lymphoma. It can be as a result of the patient going for a clipping of an aneurysm in the brain. It can be because of pituitary adenomas. It can be because of infections like meningitis. We've talked about that. It can be because of tumors like germ cell tumors. It can be because of surgery. Okay? And it can be because of many, many things. I'm just going to leave this here for you to review. Acquired AVPD occurs in more than 95% of cases. Similar distribution amongst males and females. It is not usually inherited. I want to drum that several times. Okay? Now, congenital causes, those the less than 5%, you don't need to worry your head about this. You can just look at it once and go. You don't need this for MCQ1 exam. This is too highfalutin. You are not an endocrinologist. You are not a nephrologist at this point. You are just going to write your MCQ1, which is an exam at the level of a medical student, right? So just focus on the common things. I just brought this for those who want to go a bit deep, but I'm not going to waste your time on this. So let's move on. Clinical manifestations of AVPD or diabetes insipidus, central diabetes insipidus, clinical manifestations. Number one, the patient will present with polyuria. Number two, the patient will present with nocturia. The patient pees a lot in the course of the day. The patient pees a lot in the course of the night. The patient is always thirsty and drinking lots of water. Okay? And then the sodium levels are really high. And it's because the sodium levels are high, that is why the patient always feels like they need to drink more water. So in AVPD, the patient can't concentrate urine, large volume of dilute urine, and there's increased thirst to compensate it. So like what Dr. Bironke was saying, in diabetes insipidus central, the patient is dry inside because sodium levels are high, and the patient has to always drink water to deal with that. But the patient is wet outside. Why? Because the patient is peeing a lot. So let me say it again. Central diabetes insipidus or diabetes insipidus, the patient is dry inside, hypernatremia, but the patient is wet outside. All right? Please, can I move on? So inside the body, the patient is dehydrated. That is hypernatremia. But the patient keeps urinating. And you ask yourself, why? Because a mechanism is broken. Antidiuretic hormone production has been affected. That is why it looks like it doesn't make sense that why are you dry inside but you're still peeing out a lot? Because there's a problem with antidiuretic hormone issues. Now, when does severe hypernatremia occur? Just think about a newborn baby who cannot cry and say that I am thirsty. So the patient is just peeing so much, right? But then they cannot get water independently. Number two, think about postoperative patients. They are so lethargic. Maybe they had a brain surgery. And because of that, nobody is able to recognize that this patient has developed, AVPD deficiency. Think about that acutely ill patient in the ICU who is nil per os, right? So the patient has hypernatremia, but the patient is not getting enough water. And because of that, the hypernatremia moves from normal hypernatremia to severe hypernatremia. Okay? And even there are some patients who don't have any thirst response, even though they are very thirsty. They don't have any thirst response. So you realize that severe hypernatremia can occur in very little babies, post-operative patients who cannot speak and say, I'm thirsty, acutely ill patients. Okay? And when in these patients, that is when you may see hypernatremic shock. Hypernatremic shock. So the patient is thirsty, but the patient cannot say it. And because of that, there's rising sodium level, and the patient is also peeing out the little water in the body. And because of that, the patient can get into hypernatremic shock. So think about this. Lack of water intake with rising sodium levels will lead to hypernatremic shock, which will be neurologic complications. So what are the features of hypernatremic shock? Altered mental status, confusion. The patient can also develop seizures, and the patient can have coma if the sodium levels rise too fast. In other words, if there is salt overload, the brain will shut down. Doctors, please, I want to know, can I move on? Can I move on? If you have a patient with diabetes insipidus and the patient is not getting enough water, be it because the patient is severely sick and cannot speak, the patient just had a brain surgery and therefore the patient is a bit comatose, the patient is too young, newborn baby or a child who cannot speak, that patient can have a rapid increase in sodium levels, and that can lead to altered mental status, that can lead to confusion, seizures, and even coma. Therefore, always remember in your board exam, if there is salt overload, the brain will shut down. Doctors, please, can I move on? Can I move on today, please? Can I move on? I want to know. Can I move on? Okay, good. And what are the psychological effects of AVPD deficiency? It can affect the patient's mood. The patient can develop anxiety. They can develop, social isolation. They can have reduced quality of life. Okay, so when patients also miss AVP, they can miss their emotions. All right, and it is at times it's a result of possible oxytocin deficiency. But don't waste your time on this whole thing. Just remember that if there is antidiuretic hormone deficiency or adrenaline vasopressin deficiency, it can lead to increased anxiety, it can lead to social isolation, it can lead to reduced quality of life. So, what are the takeaways? We are not done. This is just a takeaway of a summary of what we've done so far. Classic triad of diabetes insipidus. Remember, polyuria plus polydipsia plus nocturia. Serum sodium is often high, and there's the risk of hypernatremia intoxication or hypernatremia emergency if intake of water is restricted. Severe hypernatremia will lead to neurologic complications like seizures and coma. And oxytocin deficiency may contribute to mood and social behavior changes. So that is the relationship between diabetes insipidus and anxiety. And what bridges it is oxytocin. Okay? Now, diagnosis and post-diagnostic evaluation of AVPD. Diagnosis of AVPD. Doctors, so far, has it made sense? If it's made sense, please type it has made sense. So far, has it made sense? If it has made sense so far, type it has made sense. Please, it has made sense. It has made sense. It has made sense. It has made sense. It has made a lot of sense. It has made sense. Please, if it has, just type it has made sense. And then let's move on from there. But as I told you, for today, we are not rushing anywhere. We are not going anywhere. We're going to take our time. We are going to take our time. Someone says overloaded. Come on, Doc. Dr. Maham Munir says overloaded. Well, we are not going to, you know, keep anything. We're going to make sure that we teach and teach and teach. I love doing this, right? It has made sense. Okay, good. So diagnosis and post-diagnosis. But before that, I want you to know, in February alone, these are the classes you are doing in MedCognito. So February 2nd, that's tonight. So after this class, you have another class in gynecology. Then February 4th, you have MSK class in narcolepsy. Okay. Then February 6th, you have pediatrics class in MCCQE1, part 1. Then February 9th, you have another pediatrics class, part 2, MCCQE1. Then February 11th, you have an obstetrics and gynecology class in narcolepsy. Then February 13th, you have ethics part 1. And February 16th, you have ethics part 2, all MCQE1. And then February 18th, you have neurology class and hematology for narcolepsy. Okay. And then February 20th, you have emergency medicine part 1 for MCQE1. February 25th, you have cardiology and respirology for narcolepsy. And then February 27th, you have orthopedics. Now, on February 4th, before the main narcolepsy class, I will also have another class on Facebook and YouTube for narcolepsy people. So if you want to take the narcolepsy, mark your calendar, February 4th. It will be way before the main class. Okay. So it will be on Facebook and YouTube. And then on February 10th and February 18th, we'll have our med drills on psychiatry. And then February 27th, we'll have another free class on Facebook and YouTube on TDM, therapeutic decision making. Okay, good. So diagnostic and post-diagnostic evaluation of ADPD. Let's go. You have a 29-year-old woman who presents with excessive thirst and polyuria for the past 3 months. She reports drinking 8 to 10 liters of water daily. The labs show serum sodium is 145. Plasma osmolality is 300. Okay. Now the urine osmolality before the water deprivation tests or before water deprivation was 180. And then after 8 hours of water deprivation, her urine osmolality remains 190. So it looks like the urine osmolality didn't really change that much. After administration of desmopressin, her urine osmolality then rises to 600. What's the most likely diagnosis? So we are dealing with diabetes insipidus, and so we all know, right? Serum urine osmolality was just 190 after water deprivation. So it doesn't look like it changed that much. And then you gave your desmopressin and it shot the urine osmolality up. So the patient now started concentrating the urine. So if you are breaking this down, when you did the water deprivation test, the patient had unconcentrated urine. So the water deprivation test did not really help. And then you gave desmopressin and the patient now starts concentrating urine. Remember, we said that desmopressin is used for the management of central diabetes insipidus, right? So if you have a patient who is responding to desmopressin, what is your answer? The correct answer, therefore, is C, central diabetes insipidus. Okay. So water deprivation test, no urine concentration, it confirms true diabetes insipidus, not primary polydipsia. Okay. And when you gave the DDAVP administration, there was a significant increase in the urine osmolality, and therefore that confirms central diabetes insipidus. If it was nephrogenic diabetes insipidus, you realize that even when you gave the DDAVP or the antidiuretic hormone or the desmopressin, there would have been no response. So if you have a patient who has symptoms of diabetes insipidus and who responds to desmopressin, think about central diabetes insipidus. Next one. 35-year-old man with a history of bipolar disorder is evaluated for polyuria and polydipsia. So think about this. Bipolar. Remember that we talked about something initially. We said that lithium leads to nephrogenic diabetes insipidus. This patient has bipolar. Remember that. And what medication do we use to treat bipolar? Okay, so 35-year-old male with history of bipolar disorder is evaluated for polyuria and polydipsia. He drinks 10 liters of water daily. Initial labs, serum sodium is 135. So it looks like the serum sodium is low normal. Plasma osmolarity is 275. Urine osmolarity is 280. What is the next step in management? What's the next step in management? Oh my goodness, I think I made a I think I gave that out there. So this patient has bipolar. He's evaluated for polyuria, polydipsia. He drinks 10 liters of water daily. His serum sodium is 135. His plasma osmolarity is 275. His urine osmolarity is normal. So remember that the serum sodium is normal. Plasma osmolarity is also normal, low normal, but normal. Urine osmolarity is normal. Therefore, this patient does not have diabetes insipidus. This patient does not have any of those things. This patient just has bipolar disorder and probably he's taking his lithium. But then his blood levels are normal, right? His blood levels are normal. So, yes, the patient is taking lithium. I see what you guys are saying. And that's what I was also drawing attention to. The patient is taking lithium, but if you look at the blood work, it does not look like the lithium has affected him that much. It does not look like the lithium has affected him that much. So you did your blood work, your serum sodium was normal. Assuming you did your blood work and the serum sodium was, say, 155, high. Okay, then what is going on? But this patient's serum sodium is normal. Plasma osmolarity is normal, even though it is low normal. Urine osmolarity is also normal. But then you want to find out, why are you still drinking so much water? Right? Do you just go ahead and discontinue the lithium? No. Rather, you do your water deprivation test. So this patient has primary polydipsia versus diabetes insipidus, which needs to be differentiated, right? And if you want to differentiate between primary polydipsia and diabetes insipidus, the first step you need to do is to do a water deprivation test. Why is this patient drinking so much water? Okay, why is this patient drinking so much water? So in other words, this patient is drinking so much water, which looks like diabetes insipidus, but the blood work looks normal, which does not make it diabetes insipidus. So if I look at this case, this patient does not have diabetes insipidus, right? So my first step, if I'm thinking about it, is to do my water deprivation test. Okay, so water deprivation test. If the urine osmolarity rises significantly, then think about psychogenic polydipsia. If the urine osmolarity remains low, then think about true diabetes insipidus. So let's go back. I just want to find out what is going on with this patient. Okay, so my first thing is I need to do my water deprivation test. In other words, I have to tell the patient, you are not going to drink some water for some time, and we are going to check some stuff. DDIB should be only be given when you've confirmed your diabetes insipidus. And discontinuing lithium. Lithium can cause nephrogenic diabetes insipidus, but the diagnosis is not yet confirmed. Therefore, you can't just stop the lithium, which was C. And vasopressin measurements, rarely done for initial diagnosis. So, what's the teaching point here? The first step, if you have a patient who is drinking a lot of water, is do your urine osmolarity, your urine sodium, and then blood osmolarity. If they are all normal, please do your water deprivation test. Doctors, please, are we all on the same page? Are we all on the same page? Are we all on the same page? I want to know before we move on. Do your water deprivation test. Are we all on the same page, please? Please, please, please. Are we all on the same page? Why am I not going to stop the lithium? Because all the blood work and the urine tests are normal. The patient is not diagnosed with diabetes diabetes insipidus yet. Okay, good. 62-year-old man with chronic lithium use for bipolar disorder presents with polyuria and nocturia. Now look at this one. His serum sodium is 147, which is high. His plasma osmolality is 310, high. His urine osmolality before the water deprivation test was 180. Urine osmolality after you gave your desmopressin just went to 190. Which of the following is the most likely diagnosis? A, central diabetes insipidus. B, nephrogenic diabetes insipidus. C, primary polydipsia. D, syndrome of inappropriate ADA secretion. And E, hypercalcemia-induced polyuria. What's the correct answer? So DDAVP, we use DDAVP for central diabetes insipidus. But when you gave your DDAVP, it didn't really change anything much. It was just 190. What is your diagnosis then? And remember, this patient has features of diabetes insipidus: elevated serum sodium, low urine osmolality. We did our water deprivation test, didn't really change it. Therefore, we went to the next step. We gave DDAVP, but it still did not change. Therefore, what diagnosis does that tell me? The diagnosis is nephrogenic diabetes insipidus. Simple. Simple. In nephrogenic diabetes insipidus, I'll say it again, there is no response to DDAVP. Urine osmolality barely increases, and it moves from just 180 to 90, right? And the common cause of nephrogenic diabetes insipidus are lithium toxicity, hypercalcemia, and hypokalemia, chronic kidney disease. Why not the others? Central diabetes insipidus would have urine osmolality increase after DDAVP was given. But this time, DDAVP just slightly moved, nothing significant. Okay. Primary polydipsia would have a low serum sodium, but this patient's serum sodium was high. Syndrome of inappropriate ADA secretion would cause concentrated urine and hyponatremia, and hypercalcemia would cause nephrogenic diabetes insipidus. So doctors, these are the learning points. So what is my memory aid here? What is my 5D approach to diagnosing central diabetes insipidus? A, I need to detect that the patient has polyuria. That's the first step. Then I need to differentiate water from solute diuresis. So that's when I'll do my water deprivation test. Okay. And then I'll also do my blood work, including serum sodium, including urine osmolality, including blood osmolality. And then I'll do my water restriction and desmopressin test. But most of the time, my water restriction test will come first. And then I'll do my desmopressin test. If I do my water restriction test, so this is it. If I do my water restriction test and the serum and the urine osmolality goes up, then I'm thinking about primary polydipsia. If I do my water restriction test and it stays the same, and then I do my desmopressin test, I give desmopressin and urine osmolality goes up, then I know that the patient had central diabetes insipidus. But I do my water restriction test, urine osmolality is not the same. Desmopressin test, urine osmolality is the same. Therefore, I can conclude that that patient has nephrogenic diabetes insipidus. So then you have to determine the cause. You have to do an MRI, further blood testing, and genetic testing, right? Because remember that we said that nephrogenic diabetes insipidus is mostly inherited, while central diabetes insipidus is mostly acquired. Nephrogenic diabetes insipidus is mostly inherited through the X-linked route, and therefore it affects more males, while central diabetes insipidus, the genetic one is usually less than 5%. And most of those people, we don't do genetic testing for their families. And then you want to document your findings and follow up. Okay, so diagnostic criteria for central diabetes insipidus. First, I said it and I'm repeating it. I'll do my water deprivation test, and then I'll do my DDAVP. water deprivation test, if I do my water deprivation test in central diabetes insipidus, there will still be persistent polyuria and the urine osmolality will still remain low. But in psychogenic polydipsia, the urine osmolality will rise when I do my water deprivation tests. So the memory thing you need to remember is that no water, no change. So even if I stop drinking water, there will be no change in the urine osmolality. And that is true diabetes insipidus. So if urine stays dilute after you stop water, that is diabetes insipidus. Okay. Now let's break it down. In other words, use the water deprivation test to differentiate between diabetes insipidus and psychogenic polydipsia. In diabetes insipidus, you do the water deprivation test, the urine osmolality will still remain low. In psychogenic polydipsia, you do your water deprivation test, the urine osmolality will be high. Next point. After you've done your water deprivation tests, if urine osmolality goes up, think about central diabetes insipidus. If you do your desmopressin test and there is still no response, therefore think about nephrogenic diabetes insipidus. So these are the steps. Psychogenic polydipsia, I will use my water deprivation test to separate that from diabetes insipidus. And then when I've separated it, then I'll use desmopressin test to separate central diabetes insipidus from nephrogenic diabetes insipidus. Doctors, please, does it make sense? Does it make sense so far with everything we've said? Please, I want to know. I'm not moving on until I know that we are all on the same path. I'm not moving. I'm not moving. There's still more to go. I'm not moving, doctors, until I know we are all on the same path. If you're all on the same path, please let me know and let's go on. Are we all on the same path? Are we all on the same path, please? If we are not, I'm not moving. Are we all on the same path? Okay. Okay. So, patient is drinking a lot of water. Patient is urinating a lot. What's your next best step? Check your serum sodium, check your serum osmolality, check your urine osmolality. If serum sodium is normal, like that first question, urine osmolality is normal, serum osmolality is normal. Next step, do your water deprivation tests. If urine osmolality increases with water deprivation tests, think about psychogenic polydipsia. If urine osmolality remains low despite your water deprivation test, now you are torn between two things: central diabetes insipidus and nephrogenic diabetes insipidus. Then go on to give your desmopressin test. You do your desmopressin test, urine osmolality increases, boom, central diabetes insipidus. You do your desmopressin test, urine osmolality remains low, that patient has nephrogenic diabetes insipidus. So this is it. Then use the desmopressin test to differentiate between central diabetes insipidus and nephrogenic diabetes insipidus. Hello, doctors. Now we have to move on to the management and learn all the nuances. Please, can I move on now? Okay. So next question. You have a 35-year-old woman with central diabetes insipidus due to pituitary surgery, and that patient is started on desmopressin. After 1 month, she returns with new onset headaches, mild confusion, and nausea. Labs show sodium of 124. So the sodium level is low because the normal range for sodium is 135 to 145, right? Plasma osmolality is 255 and urine osmolality is 800. So you've given your DDAVP, but the patient's sodium has dropped. What's the most likely cause of her symptoms? A, chronic dehydration from undertreatment. B, syndrome of inappropriate ADA secretion from inappropriate AVP secretion. C, overuse of desmopressin leading to water intoxication. D, adrenal insufficiency from hypothalamic dysfunction. And E, osmotic demyelination syndrome from rapid sodium correction. What's the correct answer? Doctors, while you're answering, please go to our YouTube channel, MedCognito, and kindly subscribe. Let's move the channel to 2,000 subscribers. We are currently at 1,803 subscribers. Let's move it to 2,000 subscribers. So we need 197 more subscribers to move us to 2,000 subscribers. Okay. So what's the correct answer? The correct answer is C, right? Remember that I said it in the earlier part of the lecture that when you give desmopressin, it can lead to, if you give desmopressin, it can lead to severe hyponatremia. Remember, in diabetes insipidus, there is hypernatremia, and if you correct it with desmopressin, it can move it to the other side. Okay, so desmopressin can cause dilutional hyponatremia if fluid intake is not restricted. Okay, and high urine osmolality despite hyponatremia suggests continued water retention, and desmopressin therapy requires careful monitoring to prevent overcorrection, and overcorrection is what will lead to the hyponatremia. Okay, so why not the others? Chronic dehydration would cause hypernatremia, not hyponatremia, and syndrome of inappropriate ADA secretion. Patients on desmopressin cannot develop true syndrome of inappropriate ADA secretion. Okay, and adrenal insufficiency would cause hyponatremia, but with low urine osmolality. Okay, and osmotic demyelination occurs with rapid sodium correction, not gradual dilutional hyponatremia. Okay, you have a 50-year-old man with bipolar disorder who presents with polyuria and polydipsia. He's been on lithium therapy for 10 years. His labs show serum sodium of 149, which is elevated, plasma osmolality, which is 312, urine osmolality before the water deprivation test was 190, and urine osmolality after desmopressin was 200. So what does this tell you? Urine osmolality was low, and so you did your water deprivation test. It still remained low. Therefore, you've ruled out psychogenic polydipsia. Then you gave your desmopressin. You were expecting it to go up, the urine osmolality, but it still didn't go up. It just went up by 10 points, which is not significant. So that means you've ruled out central diabetes insipidus. So which of the following is the most appropriate initial treatment? In other words, this question is asking you, if I should break it down, what is the management for nephrogenic diabetes insipidus? That's all this question is asking you. First, you've ruled out nephrogenic, you've ruled out psychogenic polydipsia with the water deprivation test. Then you ruled out central diabetes insipidus with the failed desmopressin test. So now the question is asking, if you should break this whole question down, what is the management of nephrogenic diabetes insipidus? A, desmopressin. B, hydrochlorothiazide. C, high sodium diet. D, increased water intake. And E, fludrocortisone. That is all. Look, that is the way you should think in your MCQE1. Break everything down, take a step back and ask yourself, what's the question actually asking me? The question is actually asking you, if you should break everything down, what is the management of nephrogenic diabetes insipidus? And the correct answer is hydrochlorothiazide. Nephrogenic diabetes insipidus is resistant to desmopressin, and thiazide diuretics rather reduce polyuria by inducing mild volume depletion, which promotes proximal tubular water reabsorption. So I'm not going to go into the details of it. We've already spent almost 2 hours on the class, but I'm just trying to get you to it. Central diabetes insipidus, we treat it with desmopressin. Nephrogenic diabetes insipidus, we treat it with hydrochlorothiazide. Right? And if the patient is going to continue on the lithium, instead of hydrochlorothiazide, you can use amiloride. Okay? Desmopressin is wrong because it is ineffective for nephrogenic diabetes insipidus. High sodium diet would rather worsen the polyuria. Remember, the patient already has high sodium in the blood. Giving high sodium diet can even make things worse. Increased water intake is necessary but does not reduce the urine output. So in nephrogenic diabetes insipidus, you're looking for a way to reduce the urine output. Desmopressin will not work because desmopressin works on the central one, right? And fludrocortisone is wrong because that is used for adrenal insufficiency, not diabetes insipidus. Next question. 72-year-old man with hypercalcemia presents with polyuria and polydipsia. His labs show sodium of 146, plasma osmolality is 310, urine osmolality before DDAVP is 190. Urine osmolality after DDAVP is 195. Which of the following is the most important initial step in management? A, start him on desmopressin. B, administer IV normal saline. And doctors, don't get confused here, please. Don't rush into it. Remember, you are even dealing with something bigger. C, prescribe indomethacin. D, initiate hydrochlorothiazide. Be careful, I've said it. Be careful with this question. E, perform a water deprivation test. Please be careful with this question. 72-year-old man with hypercalcemia presents with polyuria and polydipsia. Serum sodium is 146, plasma osmolality is 310. Urine osmolality before DDAVP is 190. Urine osmolality after DDAVP is 195. Doctors, be careful with this question, please. Don't just assume, oh, we are doing approach to polydipsia and polyuria, therefore I'm going to give this, I'm going to give that. I've learned that nephrogenic diabetes, we give this. Please be careful with this question. There is something else you don't have to miss. There's something else you don't have to miss. This patient has hypercalcemia. Let me say it again. This patient has hypercalcemia. What is the management for hypercalcemia? Please, you give your normal saline. You give your normal saline. This patient has hypercalcemia. Hypercalcemia itself can cause nephrogenic diabetes insipidus. So if you go ahead and just give your hydrochlorothiazide without managing the hypercalcemia, it's like you are plucking off, bad fruits and you're not dealing with the roots. So there's another issue here. If you have a patient who has both hypercalcemia and nephrogenic diabetes insipidus, treat the hypercalcemia first. Give your fluids, and it will improve the kidney function. And when you are treating the hypercalcemia, it may resolve the diabetes insipidus. Doctors, please don't assume anything. When you are going into a board exam, go with your eyes wide open. Don't just say, oh, we are doing this, we are doing that, therefore that's all. No. Don't do that. Don't do that. So this question was drawing your attention to the relationship between hypercalcemia and nephrogenic diabetes insipidus. And the fact that when you have a patient with hypercalcemia, treat the hypercalcemia. Maybe while you are treating the hypercalcemia, it will help manage the diabetes insipidus as well. All right? Hydrochlorothiazide, I know some of you went for that, but hydrochlorothiazide used if hypercalcemia persists after hydration. So if you have hypercalcemia and the patient has diabetes insipidus, please try and correct the hypercalcemia first, because while you're correcting the hypercalcemia, it could be that it will help correct the diabetes insipidus. So, management of diabetes insipidus, deep dive. Let's do a deep dive. In diabetes insipidus, you are fixing two things. Number one, you are fixing either the pituitary or you are fixing the kidney. That's it. Fix the pituitary gland or fix the kidneys. Okay, so central diabetes insipidus, that is AVPD. Problem is lack of antidiuretic hormone, and so you manage it with DDAVP, which is a synthetic AVP replacement. In nephrogenic diabetes insipidus, the problem is the kidney is resistant to AVP. That is why in nephrogenic diabetes insipidus, you realize that the patient will have normal AVP levels, but the patient still has, polyuria, right? And so in nephrogenic diabetes insipidus, You correct the issue. If it is hypercalcemia, correct that. If it is lithium causing it, stop the lithium. If it is hypokalemia, correct the hypokalemia. And then you can use medications like hydrochlorothiazide and amiloride. Okay, and NSAIDs like indomethacin can also be used. So, nephrogenic diabetes insipidus, you can give NSAIDs, or remember that the nephrons need thiazides. In central diabetes insipidus, give long-term desmopressin. So, takeaways on diabetes insipidus treatment. Desmopressin overuse can cause dilutional hyponatremia, which will lead to water intoxication. And the whole class said what? Amen. Right? Doctors, and the whole class was happy. And the whole class was happy. Right? Please, we've moved through the epidemiology. Someone says last slide. Sure. We've gone through the epidemiology. We've gone through the etiology. We've gone through the distribution. We've gone through the population health relationship. We've gone through everything. And the whole class said amen, from India to Iran to South Africa to Azerbaijan to Iceland to everywhere. Diabetes insipidus. Diabetes insipidus. Doctors, diabetes insipidus. Always remember, desmopressin overuse can cause dilutional hyponatremia, which is water intoxication. I'm going to end it here. I know you guys are going to start calling me, so please reach out right away. +1 306 891 5649. Remember, you have a class tonight in gynecology. All right? And then med drills, February 10th, February 18th. On the 4th of February, there's going to be someone look at what somebody's saying. I wish I can get now some questions about diabetes insipidus in the real exam. Good. I'm very happy about it. And then someone says, make it simple. Thank you, Dr. Bruni. Good. Someone also is like, giving a prayer emoji. Thanks a lot, Dr. Bruni. Someone also says, excellentos. Good. I'm happy. Now, diabetes insipidus cannot beat you in the exam. And remember, it's a major MCCQE1 objective, right? So from coast to coast, from east to west, from north to south, doctors, I'm expecting your WhatsApp messages right now. Reach out right now. We are here to help you. Okay? We are here to help you. Even with 1 month access for $450, you can still get access to everything in MedCognito and get access to our med drill for free. Okay, for just $450. All right. What is this? Someone says what? Just checking this. Says, thank you so much, sir, and be happy forever. Nothing is impossible. The world itself says I am possible. Okay, sure. Thanks a lot. Everyone is saying thank you. How can we get this recorded video? Oh, it's going to be on YouTube and it's going to be on Facebook. So as soon as I end it, you can watch it right away. Okay? It's there for you, doctors. I'm doing this for you. So, doctors, thank you very much. Please reach out right now. This is my phone number. Reach out. +1 306 891 5649. You can sign up right now and join a gynecology class tonight. Sign up right now, join a gynecology class tonight for just $420 a month. Just $420 a month, or $2,199 for 6 months access. People are charging $5,000, $3,000, and all those things. But with just $2,199, doctors, you can have access to everything in MedCognito. Okay. All right. Thank you very much and enjoy your day. Bye-bye.